Hello everyone. Our topic for tonight is going to be about dengue fever. Dengue fever is the most common arbovirus infection of humans. It's transmitted by a mosquito. It's a flavivirida single-stranded RNA. We have 4 serotypes: DENV1, 2, and 3, and 4. Once you get infected with a certain serotype, usually you acquire a long-life serotype-specific immunity. It's usually a self-limited acute febrile viral illness that has plagued the tropical region of the world for centuries. As we can see, it's a part of the genus Flavi of the family Flaviviridae, along with the West Nile virus, yellow fevers, St. Louis, and Japanese encephalitis, and all the others. Let's go back a little bit in history. As we can see, Dr. Benjamin Rush, a professor of chemistry and medical theory at UPenn, was the first one back in 1780 to describe the dramatic symptom of dengue as a breakbone fever. And then World War II back in 1930 played an important role in the spread of dengue fever through Asia Pacific region. Until the 1970s, the epidemics were only limited to 9 tropical countries. But in the last 50 years, and secondary to the unplanned urbanization in tropical developing countries, secondary to the modern transportation, lack of effective mosquito control, and globalization, we had an alarming rise in cases, with incidence increasing 30-fold. And now, dengue has become endemic in more than 100 countries in the tropical and subtropical region of the world. It's estimated now that we have 50 to 100 million infections per year worldwide. Over 2.5 billion people are at risk of infection. The mortality can go between 5% and less than 1% with appropriate therapy. Usually we get seasonal outbreaks since the warm and the wet conditions favor the development of these mosquitoes that usually breed in water. And whenever we have high humidity and rainfalls, we get stagnant pools where this mosquito population can explode. Some countries, they have a risk of dengue that exists year-round. These countries where we have the hyper-endemic dengue. But usually, finally, the worldwide outbreaks occurs every 20 to 40 years. As you can see here, this map shows the regions that are potentially susceptible to dengue based on climatic and environmental variables such as temperature and available moisture. And now, because of the global warming, we're expecting that the dengue risk is going to move further north. Let's talk a little bit about the vectors. The main vector, as we all know, is the Aedes aegypti. It's a yellow fever mosquito. It's usually a day biter and lives in the tropical and subtropical areas. As for the second vector, the Aedes albopticus, it's also called the Asian tiger mosquito. It's a day and night biter. It's as competent as Aedes aegypti to cause the transmission of a dengue virus, but it doesn't do it as often because it doesn't bite a human as often. And the Aedes albopticus has the capability to sustain colder weather, so we see it more in the northern areas. So what do you think this one is? As you can see, the white markings on the legs and the bright silvery lyre-shaped dorsal pattern. This is the mosquito that came from Africa, and this is Aedes aegypti. As for this one, we have the black and white striped legs and the small black and white striped body with a single long silvery dorsal stripe. And this one originated from Asia, and this is the tiger mosquito. Yes, dengue is moving north. U.S. outbreaks to date, and they are mostly caused by dengue 1. In 2001, we had an outbreak in Hawaii, 2007 in Texas, and before 1934, the first outbreak in Florida was in Key West. In 2009, we had 22 cases. 2010, 66 cases of locally acquired dengue. 2012, 4 resident locally acquired dengue, 2 were in Miami and 2 near Orlando, with another 112 cases were imported from elsewhere. Let's talk about pathogenesis. So, usually after the bite of dengue, the virus infects immature dendritic cells that they go and migrate to the lymph nodes, where you get an activation of the cellular and humoral immune response. The viral will continue to replicate in the macrophages for 3 to 6 days, which is the incubation period prior to viremia. And once the viremia occurs, 6 to 8 hours later, you start having the symptoms of dengue fever. And then the viremia and the fever will both end together. But once the fever starts, there's a period of 2 to 10 days where the victim can cause an infection in the next mosquito that bites him or her. And once the mosquito is infected with dengue virus, it remains infectious for its entire life, which is 1 month. Now, we all know that the secondary infection of dengue is the one that leads to the more severe cases. But what is the mechanism behind that? It shows that it's because of the antibody-dependent enhancement. Because once you're infected with a certain serotype of dengue, you develop neutralizing antibodies against this certain serotype, but you develop a transient cross-protection against the other serotype. So once you're infected with a second serotype, you will get immune complexes between the dengue virus and the non-neutralizing antibodies. And these immune complexes will infect the macrophages and will cause an exaggerated immune response with a cytokine storm, which will disrupt the vascular permeability. In here, in this slide, we're trying to explain how the pathophysiology of endothelial dysfunction in the cases of severe dengue secondary infections occur. Even though the mechanism is still unclear, but there's a hypothesis that says that the virus with its non-structural proteins bind to the glycocalyx layer of the endothelial cell wall, causing release of heparin sulfate into the circulation, which is an anticoagulant, and transiently disrupting the endothelial cell wall, causing leakage of protein coagulation factors to the extra endothelial space. And this is how you get the plasma leakage and all this. Clinical manifestations. So now we have a revised, the World Health Organization has did a revised classification in 2009, replacing the one that was in 1997. As you can see, they divided into dengue without warning signs, dengue with warning signs, and severe dengue. Dengue without warning signs is characterized by fever and 2 of the following: nausea, vomiting, rash, aches and pains, leukopenia, and positive tourniquet sign. As for the dengue with warning signs, this is the very important one, because this should alarm us about the risk of developing into a severe dengue. Is the dengue as defined before with any of the following: abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, restlessness, liver enlargement, or laboratory increase with the rise in hematocrit and a rapid decrease in platelet count. And the dengue with warning signs is the one that usually can progress to severe dengue. Severe dengue is the fatal case of dengue fever. This is the dengue with at least one of the following criteria. Either you have a severe plasma leakage leading either to dengue shock syndrome or to fluid accumulation with respiratory distress, or you have severe bleeding, dengue hemorrhagic fever, or severe organ involvement. It can involve the liver causing transaminitis of 1,000 or more, CNS with impaired consciousness, or congestive heart failure or failure of other organs. So after an incubation of 3 to 7 days, we have 3 phases of disease: the febrile phase, the critical phase, and the recovery phase. The febrile phase, which usually lasts 3 to 7 days, it's characterized by the fevers, the headaches, the myalgia and arthalgia. For that, it's called the backbone fevers. And you can have a transient macular rash. And if there's any hemorrhagic manifestation in this phase, they will be very mild, like petechia, bruising, mild or moderate thrombocytopenia, and very mild transaminitis. Then comes the critical phase, and this phase usually occurs at day 4 or 7 of the illness. It's around the time where you start having the fever starts to wane, and in this phase you will notice progression of leukopenia and thrombocytopenia. And this is the critical phase, because this phase is the phase where you can the plasma leakage can occur, leading to the dengue shock syndrome, to the third spacing, to the hemodynamic instability, or the hemorrhagic manifestations also can occur in the critical phase with skin and mucosal bleeding with only minor plasma leakage, and shock. Recovery phase. Recovery phase is the phase where you get resorption of all these leaked plasma. You get stable hemodynamic status again, the urine output will increase. In this phase, usually, people can develop a rash that could be very mild maculopapular rash or a severe leukocytoclastic vasculitis that resolve with desquamation over a 1 or 2 week period. And it's usually followed by profound fatigue that lasts for several weeks. So here we can see some of the hemorrhagic manifestations of dengue fever. In the first panel, we can see the typical petechial rash in an infant with a dengue. On this panel B, you see minor bleeding around the injection site, which is a very common feature in dengue. In panel C, you see a hematoma in a patient with a severe dengue. And in panel D, you see in the recovery phase, this is the maculopapular rash, the macular rash surrounded by this white islands. It's very characteristic for that. So here I'm going to pinpoint again about the importance of these warning signs. Whenever you have dengue, you have to be very careful about the warning signs, because they are the ones that alarms you that this patient will need strict observation, medical intervention, needs very frequent monitoring of his hematocrit and blood pressure. The warning signs again are the abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement, and an increase in hematocrit concurrent with a rapid decrease in platelet count. Diagnosis, it's based on the clinical signs with or without travel history nowadays, and the diagnostic test. We have two types of diagnostic tests. We have the direct that are able to detect the viral components in the serum, which are the reverse transcriptase PCR, and the non-structural one antigen detection by ELISA or lateral flow rapid test, and the indirect tests, which are the serology. As you can see, from the first day of illness, we can start detecting the dengue through the direct diagnostic tests, which are either detecting the nucleic acid by the reverse transcriptase PCR or the non-structural protein that is produced by the virus. As for the fourth day, as early as the fourth day, you can start seeing the IgM in the blood. Non-structural 1 antigen, it's a structural protein secreted by all the flavivirida. It's detectable up to 10 days after the onset of the illness and disappear once a seroconversion has occurred. There's a lot of methods that can diagnose, that can detect the non-structural antigen. You have the ELISA, the rapid test lateral flow, the serology also for this non-structural protein. And there's a lot of commercial rapid tests available that takes only 15 minutes to detect this antigen, but they are not FDA approved. And the problem with this test that it's also cross-react because it's positive in all other flavivirida. The rapid tests are available for the serologies along with the non-structural protein. And they take only 15 minutes, but the problem they're not available in the US. For the reverse transcriptase PCR, they are useful for the first 5 days of symptoms with a very good sensitivity and specificity. They were FDA approved back in 2012 for diagnostic use in the US. And they start distributing them back in July 2012. As for the IgM serology, it's detected as early as 4 days after the onset of fever. False positive can occur secondary to cross-reactivity with other flavivirida. Sensitivity is also, good if it's a primary infection, but it goes down if it's a secondary infection. And the FDA has approved the use of a MAC ELISA back in April 2011. Usually if you get a single sample, serum sample, it just gives you a presumptive diagnosis. The only way to get a confirmatory diagnosis is to get paired sample that shows an IgM seroconversion. IgG ELISA, it's not FDA approved, it's commercially available. It's also a confirmatory test. The good thing about it that it helps you differentiate between primary and secondary infections. It tells you if it's a secondary infection if you have more than 4 times rise in a paired sample. Now these two last tests, which are the viral cell culture and the PRNT, are very labor intensive and they require research laboratories or certain state health laboratories, and they take a long time. But they are able to stereotype the dengue virus and they are very specific. For more information about these tests, you can go to this side. Management. Of course, there's still no drugs available for the dengue virus, so the management remains supportive. Don't give aspirin, steroids, NSAIDs because of increased risk of bleeding, so we only have acetaminophen for the pain and fever. All you need to do is monitor for development of plasma leak by checking serial hematocrit, hydration status, blood transfusion only if significant bleeding, because we don't want to cause any iatrogenic pulmonary edema, because as we saw that in the recovery phase, we're going to have a resorption of all the plasma that was leaked out. So in case we gave him a lot of fluid, we're going to lead to iatrogenic pulmonary edema. This algorithm is also from the World Health Organization, and it tells you step by step in a case of hypotensive shock. It tells you step by step in a case of hypotensive shock how to challenge the patient with fluids, followed by checking the hematocrit and assessing the patient's status, and then deciding if it needs to be re-challenged or not. Yes, no vaccinations yet, but as it shows that the ideal dengue vaccine should be able at least to protect against disease caused by all 4 serotypes. But however, if we think about it, because the incidence of severe disease following a 3rd or 4th dengue virus infection is very low, it's possible that a trivalent response may be sufficiently protective. While no licensed dengue vaccine is available, several vaccine candidates are currently being evaluated in clinical studies. The candidate currently at the most advanced clinical development stage is the Denvax. It is now in phase 3 efficacy studies. It's a tetravalent live-attenuated dengue virus strain based on a chimeric yellow fever and a dengue virus. The result from the phase 2b trial that was done in Thailand has been published in September 2012 and showed that this vaccine was able to induce a trivalent neutralizing antibody response in 90% of the children. But for unclear reasons, the vaccine failed to protect against the Dengue2, which was the prevalent serotype in the region of Thailand. Another candidate of dengue vaccine that was developed by the National Institute of Health is the TV003. And the phase 1 clinical trial was recently published in the Journal of Infectious Disease issue of January 17, 2013. The phase 1 clinical trial was able to show that a single dose of this live-attenuated tetravalent vaccine was able to induce a trivalent or greater neutralizing antibody response in 90% of the flavivirus-naive adults. And what is attractive about this vaccine that the production cost of it's very, very inexpensive. It's less than $1, which made it very attractive to the developing countries. And now a phase 2 trial is going to start to evaluate the TV003, and its capacity to create an immune response will begin soon in Brazil and Thailand. And of course, now in the horizon, because we have a dengue mouse model that's been validated and demonstrated to be a suitable test system for the antiviral drugs, there's a lot of studies and clinical trials that are going on, still in early phase, that are trying to study the new antiviral medication and medications that are targeting the immune response to dengue. There's like some exotic new approaches to target the vector are going on. One of them is a gene-modified male mosquito that contains a gene that causes the offspring to die before maturing. The trial was already done in Cayman Islands, in Brazil, and in Malaysia, and they are using it, where they released 3.3 million of gene-modified mosquitoes, Aedes aegypti, resulted in 80% reduction in the mosquito population in the Cayman Islands, 90% in Brazil. But the mosquito control officials in the Florida Keys are awaiting approval from the federal government to begin releasing hundreds of thousands of these gene-modified mosquitoes first in the US. They will be the first in USA. But now remains the fear of the unknown. What if these gene-modified mosquitoes turned out to be superbugs, immortal, spreading other diseases? So, question mark about that. Yeah. Alternative strategy is embryonic introduction of strains of the obligate intracellular bacterium Wolbachia into the Aedes aegypti. And the Wolbachia infected Aedes aegypti are partially resistant to the dengue virus infection. And since this Wolbachia is able to invade the natural aegypti population, this will lead to possibility of induction of widespread biological resistance to the dengue virus in Aedes aegypti population. So until then, the best hope of stopping this epidemic and the advance of dengue fever relies on our individual actions, which is the mosquito control is the most effective approach by using insecticide, reduce the breeding sites, discard any tires, other containers that accumulates water after every rain, wear repellents, and maybe convincing people to stay inside. This is the top 10 mosquito love nests that's published by the Ontario Ministry of Health. Thank you.